pathophysiological changes that seen in the body because of burns. So it is divided into a lot of parts, one being the local changes, that is the local inflammatory changes that occur onto the skin. It causes damage to the skin and the underlying structures and leads to membrane disruption, protein denaturation and necrosis. It extends from skin to the deeper surface depending upon the time of exposure to the injury. And now there are three reactions or tissue injury. One is zone of coagulation, zone of stasis and zone of hyperemia. Now there are three zones, what I said. Zone of coagulation, it is the centermost part, that is the most burnt area, and that part is irreversible. Then there is zone of hyperemia that surrounds the zone of coagulation, that is the outermost. Because of vasodilatation there is hyperemia and redness, and that recovers. And then there is zone of stasis, that is in between hyperemia and coagulation. Now there is inflammation and edema because of burns. There is massive increase in inflammation which is response to the injury. Okay, initially when there is a burn surface area of 10%, then there is local inflammatory response. But as soon as the burn surface area increases more than 20%, there is a generalized or systemic inflammatory response. Now the mediators include cytokines, chemokines and other inflammatory cells. Fluid shifts to the interstitial space because of increased vascular permeability. And if there is shifting of fluid to the interstitial space, what will happen? If the fluid shifts from the blood vessels onto third space, what happens? Anyone, someone from final year, tell me. You tell me. This is very basic because this is something that you need to understand, be it medicine, be it surgery. If fluid from the blood vessels go out, what will happen? There will be hypovolemia. And then hypovolemia will lead to shock. Okay? Cardiovascular changes. All these changes are important because this you have to write in your exam because this is a 20-mark question, burn. There is initially a decrease in the cardiac output because of hypovolemia, and myocardial depressant factors are also released and increased systemic vascular resistance is there. Apart from that, there is increased oxygen consumption and heat production persists from months. Increased capillary permeability, this I have mentioned already. Now let's come to pulmonary changes. Now direct injury to the lung is very rare. Injury to the pulmonary system occurs only because of inhalation of the side effects of the thermal injury, that is soot and other things. Smoke inhalation causes chemical injury to airways and lung parenchyma. It is basically smoke that you are inhaling and results in mucosal edema, bronchospasm, increased secretion and impaired gaseous exchange. And also other things like carbon monoxide poisoning is also important, that leads to pulmonary changes. Now immunological changes. This is very important because a patient of burns has reduced immunity that can give rise to systemic infections also. So this has to be dealt with. It causes profound immunosuppression. Why it happens? Because there is impaired neutrophil function, macrophages functions are impaired and decreased lymphocyte production. Sepsis remains a leading cause of death in burns and hence immunological changes and patient has to be dealt with antibiotics and proper wound care. Increased susceptibility to infection is there. And also oxidative injury to the cells because of the burn itself. Endocrine and metabolical changes. Now because of any stress to the body, as you might have read in medicine if at all, there is increased release of cortisol, insulin, glucagon. And also because of these things, what will happen is protein breakdown will start to happen and muscle breakdown will happen. And also lipid metabolism is altered, which increases fatty acid mobilization. And it causes negative nitrogen balance. Muscle loss is there and this initially there is a catabolic state, that is body tissue starts to break down. So that you have to deal with and hence this is important, endocrine and metabolic changes. I have mentioned everything point wise, you can take the slide and it can help you in writing the answer later on. So this burn injury leads to a hypercatabolic state which I mentioned before. And this process contributes to muscle wasting and weakness. Obviously, to any kind of injury, there is a psychological response. This you should know that it can lead to stress, anxiety, and later on to PTSD, post-traumatic stress disorder. Now, there are three phases of response to trauma. That is ebb phase, that is the low metabolic rate initially, followed by the flow phase, following resuscitation to the injury, there will be a flow phase. And in flow phase, there is a catabolic flow phase and there is an anabolic flow phase. This is a flow chart. This is a diagram showing the metabolic response to burn. Initially, there is altered hemodynamics leading to vascular permeability and edema, immunosuppression, hypermetabolism, and decreased renal blood flow. Why will there be decreased renal blood flow? Anyone? Okay, but what will happen because of albumin? That is not because of albumin. That is because of hypovolemia. If there is reduced blood in the blood vessels, then obviously lesser blood will be entering into the renal system, right? So that is a basic understanding. That is why there will be decreased renal blood flow leading to oliguria as well. Now again, this is a diagram showing what are the problems, metabolic problems that happens because of burn. There is increase in fatty acid and glycerols because lipid oxidation happens, and also there is, because of cortisol, there is bone calcium and magnesium resorption. Now let's come to classification of burns. This is a very important topic. This comes as a short note. So initially the classification will be based on the type of injury. Type of injury, what I said, is flame, scald, contact, chemical and electrical. Apart from that, it can also be classified on the basis of depth of burns. One is superficial burns, injury confined to epidermis. Superficial partial thickness, superficial deep thickness, and a full thickness burn. So you have to just mark these things up. This is for something for you to remember. Superficial is confined to epidermis. Partial thickness is epidermis and papillary dermis. Partial deep thickness is epidermis and dermis. And full thickness is involving other muscle and bone. Again, there is one more classification. This is first degree, second degree, third degree and fourth degree. So first degree corresponds to the same thing as superficial. Second degree as partial thickness. Third degree as full thickness. And fourth degree as extending into the muscle, bone or fascia. Now, calculation of burn surface area, this is very important because you might get a question stating that patient shows burn in the thigh, in the torso and in the trunk, and then you have to calculate the burn. It differs from each child. In child, the difference is that both legs are 13.5 and 13.5%, whereas in adult is head is 18%, and in adults the head is 9%. These differences, this chart you have to mug up because they can ask you to calculate the burn surface area. And why burn surface area is important? Calculate the volume loss and volume repletion, what you have to give back to the patient. Now let's come to treatment of burns. So in treatment, what you might think the only treatment is fluid therapy or management, that is not the case. Initially you have to start with the pre-hospital care, and this you have to mention properly because you have to stop the burning process and remove the burning clothing. You have to remove, and after that you have to cool the wound. So this is the pre-hospital treatment. What you have to mention, that the care has to be given before the patient comes to the hospital. You have to manage the airway, suspect inhalational injury in flame burns, administer 100% oxygen via face mask, and pain management. You have to cover the wound, whatever the burn area is there, you have to cover the wound with a dry and antiseptic, if possible, dressing. Let's come to the initial assessment. The ABC of any trauma that you see: airway, breathing and circulation. Now suspect airway injury has to be suspected because of case of burn if there is smoke inhalation, and prophylactic intubation has to be provided for any person with more than 40% total burn surface area, and patient has to be monitored for hoarseness or stridor. Breathing, also again, in case of burns, there is formation of eschar, that is the dead burnt area. Now why eschar is important? Because if that eschar is on chest, it can inhibit chest movement, and if chest movement is inhibited, patient will not be able to breathe, and hence breathing has to be seen along with that presence of eschar or not, and escharotomy has to be done to ensure that the patient breathing is proper. Circulation, you have to check if pulses and BP, you have to check the patient, and if supposedly the area of the pulse where you check is burnt, you have to use a Doppler. These are just points you have to mug up. Disability exposure, you have to see for cervical spine if it is injured or not. Let's come to resuscitation. Now in resuscitation, even in your for your exam later on also, this is important because they'll ask you the formula for that Parkland. So basically the most important is the Parkland formula, wherein you have to multiply it by 4. 4 into TBSA, total burn surface area, into the body weight of the patient. Now you will get a total amount. Let's say the amount is 3000 liters, 3000 ml, sorry, 3 liters. So in 3 liters, 1.5 liter is given in the first 8 hours, and the next 1.5 liters are given in the 16 hours. This is important. Other formulas, you just have to mug up the name, Brooks formula and the Galveston formula. Galveston is used in pediatric population, and Brooks formula is 2 into the total burn surface area. Now, initial 24 to 48 hours, the fluid of choice is the ringer lactate. And after 48 hours, you have to replenish the body, the blood vessels, and for that you have to use colloids. That is either blood products or Hemaxel, dextrans can be used. Apart from initial resuscitation, you have to monitor patient's output. That is, you have to insert a urinary catheter to monitor whether the urinary output is adequate or not. Pulse and BP has to be monitored, and Ryle's tube has to be inserted to prevent any kind of aspiration. And feeding purposes also. Monitoring what I said, NG tube and pulse, BP, PCO2 monitoring. Tetanus has to be given along with immunoglobulins if patient has not received any kind of tetanus toxoid before. Now let's come to wound care. Wound care can come as a short note for you guys. So pre-hospital you have to cover the wound with a clean dry dressing. Apart from that, what I said about escharotomy, if there is dry, dead, black skin which prevents movement of chest or any other organs, you have to remove that, excise the eschar. Circumferential full thickness burns which compromises circulation, this is called as an eschar, and it has to be incised. Now key points over here is early cooling and limit the 3 hours post injury. Fluid resuscitation, you have to look for airway edema and escharotomy. These are the key points in treatment that you should remember. Now let's come to inhalation burn. The chances of you getting this as a question is less, but it is better to know about this. Mechanism of injury, it can be because of chemical, thermal or systemic toxins. Like systemic toxins here will include carbon monoxide or hydrogen cyanide. Now tissue response, what happens in response to smoke is that there is increased bronchial blood flow which leads to edema, and protein rich lung lymph leads to increase in capillary permeability. There is neutrophil infiltration, release of proteases and oxygen free radicals. There is epithelial sloughing that can lead to fibrin cast formation that can prevent gaseous exchange and lead to barotrauma or pneumothorax. Diagnosis is basically clinical signs will help you with diagnosis. Closed space exposure, hoarseness, wheezing, all these things, and carbon monoxide poisoning, patient will present with headaches. Other diagnostic tools are obviously bronchoscopy, and you can look for alveolar air oxygen levels. Now management. Initial management always includes giving 100% oxygen to the patient or hyperbaric oxygen where it is a possibility, or you can also consider HFOV, the high frequency oscillatory ventilation, and other CPAP measures. These are something that you should learn. Pulmonary toileting and fluid resuscitation is there. Clinical phases of inhalational injury. This is some acute phase, pulmonary edema and infection. There are 3 phases. Now let's come to burn wound management. Now there are 3 stages of wound management. One is assessment, management and rehabilitation. Now let's come to wound. Once wounds are assessed, debrided, they are managed in 3 phases. Dressing. Any dressing should protect the epithelium, prevent or decrease heat loss, offer comfort and minimize bacterial and fungal contamination. Now dressing selection depends on the wound characteristics, depending upon how thick the wound goes on to. Minor wounds may not need dressings. Salves. What is salves? Salves are basically antimicrobial creams that can be applied that serve as a dressing. Now partial thickness wounds, daily dressing with antibiotics, gauze, elastic wraps, but deep burns require biological dressings. Let's come to antimicrobials. There are 3 classes of antimicrobials: salves, soaks or antimicrobial dressings. Now what are salves? They are applied to wounds or directly. Examples are 11% mefenide acetate, silver sulfadiazine, as you might have heard of silver sulfadiazine, bacitracin, polymyxin B, and nystatin. Now these are some different salves that are used along with the side effects. Go through these: silver sulfadiazine, mefenide acetate, petroleum-based agents. Now antimicrobial dressings. Silver dressings have longer wear time, and systemic antibiotics. Systemic antibiotics are given when you suspect more than 30 to 40% total burn surface area is there. You have to give to prevent any kind of systemic infection. Pathogens of concern here are Staphylococcus aureus, Pseudomonas, and Klebsiella. Now, biological dressings. What are biological dressings? There are different types of biological dressings. That can be a skin grafting is there. In skin grafting, there are two types: a split thickness and a full thickness. Apart from self-grafting, there is xenograft, cadaveric skin, and allografting. It must be applied within 72 hours. Apart from this, there are certain synthetic dressings also, which include BioBray, Suprathel, and dermal equivalents. Dermal equivalents are Integra, collagen, and silicone. These are something that you have to just mug up. Excision and grafting. Deep burns don't heal well without grafting. You have to graft, whether it can be split or full thickness. Split thickness grafting is the common method that is used because you can do it in multiple times. You can do it, and it is often meshed because once you mesh the split thickness, it offers a larger area for coverage. But in full thickness, now in split thickness, what happens is that you can cover a larger area, but in full thickness, the coverage is less, but the coverage is better. In full thickness, blood loss is a risk, so you should avoid full thickness in such a burns patient. What is the causes of skin graft loss? It can be because of fluid collection, infection, or poor technique. How do you prevent it? By bolstering, immobilization, and antibiotics. Now again, you can also use cultured epithelial grafts. This is something, just a theory. Keratinocytes grown from small biopsies. This is for something for you to mug up. Again, this is burn scar management, what I said, full thickness grafts and split thickness. Tissue expanders can be used. It can be used to increase the graft take-up. There is also something called as the vacuum assisted closure. Does anyone know of vacuum assisted closure, VAC dressing? Negative pressure wound therapy? No one. Diabetic wound dressing, ulcers. You've read what is negative pressure wound therapy? No. Negative pressure wound therapy is to any wound that you are providing negative pressure, that is a minus 15 millimeters of mercury is provided, what it helps with. So basically what happens when you provide negative pressure, there is continuous suction of the inflammatory mediators and other serous discharge from the wound, and also because of the negative pressure there is improved vascularity to the area that helps with enhanced recovery to the wound. Okay. Now let's come to nutrition in burns patient. Like I said, burns is a hypermetabolic state. The nutrition plays a very big role in managing burn patient. Now, caloric requirement, there are two formulas in adults. One is the Currieri formula and Harris-Benedict formula. And children, there is a body surface area based formulas. These are some things you have to mug up. Now, what is the diet composition? Protein, you have to increase protein supplement to such a burns patient because to monitor the albumin and replenish the albumin that has been lost. For that, you have to give 1 to 2 kg per day protein. And non-protein calories, they prefer carbohydrates, and preferred delivery route will always be the oral route compared to the parenteral route. Now let's come to organ failure in burns patient. Different organs can fail, one being the hepatic failure. Why? Because there is impaired protein synthesis that can lead to coagulopathy. Basically in hepatic failure there is coagulopathy that has to be taken care of and replace coagulation factors, albumin infusion for hypoalbuminemia. Renal failure is there, like I said, there is hypovolemia, decreased GFR, oliguria. You have to maintain fluid status of the patient and look for urine output and dialysis in severe cases. Pulmonary failure, like I said, smoke leads to pulmonary injury, and that early intubation, 100% oxygenation, antimicrobials has to be given to the patient. Hematological failure because of coagulopathy secondary to hepatic failure, that has to be treated with. Thrombocytopenia has to be treated accordingly. Now, key points over here is that liver, factor replacement, hematological platelets, renal has to be dialysis in case of severe cases, and pulmonary is, to prevent pulmonary injury, you have to extubate early. Now, let's come to the next short question for you guys. Then next is contracture in burn wound. Once the patient's burn has been taken care of, the second thing that can happen in such a wound is the wound can develop contractures because there is increased type 3 collagen in the burns wound. So it can occur anywhere, but it is more common in cases of joints, lip, shoulder, neck, elbow. It can be because of intrinsic loss of tissue or because of extrinsic pull. And it proceeds towards the position of comfort or until it meets the opposite area. Okay? There is wound shortening and overformation of type 3 collagen. Now, what are the complications of Burns contracture? It can lead to ectropion of eyelid, disfigurement of face, narrowing of mouth, microstomia, contracture of neck, hypertrophic scar, keloid formation, pain and tenderness in scar formation, and lastly, Marjolin's ulcer can form. Now, treatment of contracture is the commonly you must have heard the Z-plasty or release using skin grafting. Different flaps can be used, and apart from that, supportive measures include physiotherapy and pressure garments. Let's come to prevention. Exercise has to be given post burns. Physiotherapy is a must to prevent formation of contracture. Pressure garments have to be given, and topical silicone sheeting can be applied to prevent contracture.